Tanto, bueno, muy buenos días, muy buenas tardes para todos. A nombre de la Sociedad Boliviana de Ortopedia y Traumatología, darle la bienvenida y un agradecimiento a la Asociación Argentina de Hombro y Codo por colaborarnos con este webinar sobre artroscopía de codo. Un agradecimiento especial para Juan Pablo y la doctora Alessandra, que nos van a brindar toda su experiencia. Muchísimas gracias por acompañarnos. Las preguntas, por favor, las pueden realizar por el chat y una vez terminada la exposición las vamos a realizar. Muchísimas gracias y comenzamos, por favor, con Juan Pablo.
Bien. Bueno, muchas gracias. Ahí está, me escuchan, ¿no? Muy bien. El tema que voy a tratar es iniciando la artroscopía de codo, ¿no? Para aquellos que estén interesados en comenzar la artroscopía de codo, es un tema muy interesante. Cada vez hay más tratamiento indicado, mayores patologías que podemos tratarlas de esta manera, pero hay una gran realidad, y por eso mucha gente no se ahonda todavía en la artroscopía de codo, quizás, es que todas las patologías de codo pueden ser tratadas de forma abierta, ¿verdad? Eso es una realidad a la cual todavía no le podemos escapar. Entonces, ¿por qué hacemos artroscopía de codo? Bueno, hacemos artroscopía de codo por este tema, que son todos abordajes e incisiones mínimas. Esto permite menos disección y tratar la misma patología, por ende menos sangrado, tener menos dolor, y además permite hacer una inspección articular. Entonces son varias las ventajas que tiene hacer una artroscopía de codo. Ahora, este es un caso muy sencillo, ¿no? Este era un paciente de 34 años de edad con limitación de la extensión del codo por un osteofito marginal muy evidente. Y estos pacientes con dos portales de 5 milímetros los podemos liberar completamente, nada más sacando el osteofito ya ganan margen de movilidad. Ahí es una de las cosas tan útiles de la artroscopía de codo, ¿verdad? Ahora, ¿por qué no hacemos artroscopía de codo? Bueno, este es el mayor tema, ¿no? Porque hay riesgo de lesión neurovascular. Eso es la verdad. El codo es una articulación compacta, es profunda, y salvo su cara posterior, ¿verdad? Y está en zona de tránsito neurovascular. Y uno no está tan acostumbrado a hacer artroscopía de codo como artroscopía de otras partes del cuerpo. Requiere una metodología artroscópica. Ahora, toda esta metodología artroscópica y la forma de hacer la artroscopía de codo ha ido evolucionando alrededor de que sea un procedimiento seguro, ¿no? Porque si el mismo procedimiento lo puedo hacer de forma abierta y por hacerlo de forma artroscópica voy a tener una lesión neurovascular, no vale la pena hacerlo. Entonces, el objetivo de esta presentación es repasar los aspectos de seguridad para una artroscopía de codo, algunos conceptos básicos de cómo iniciarla y describir los portales básicos nada más. Después Alessandra les va a comentar mejor cómo ver todo el codo en profundidad. Entonces, algunos pasos que pongo para un procedimiento seguro, deben haber muchos más, pero estos para mí son los principales. Lo principal y primero es el conocimiento de la anatomía regional. No podemos dejar de saber en detalle dónde están las estructuras neurovasculares más importantes del codo, sobre todo su relación con las estructuras óseas, que es lo que nos va a servir a nosotros de referencia externa para ingresar al codo y trabajarlo. La posición del paciente es muy importante. Puede ser de forma supina, con el brazo colgando, en forma prona o en decúbito lateral. A mí me han enseñado a hacerlo en decúbito lateral y yo tuve la suerte de aprender de hacerlo de gente que hace muchas artroscopías de codo por año. Me parece muy seguro, no solo para nosotros, sino para el anestesista, que puede tener acceso fácil a la vía aérea, y nosotros lo colocamos en un soporte, lo ponemos en decúbito lateral con un soporte del brazo. Entonces el codo tiene poco movimiento lateral, pero nos permite hacer flexión y extensión del codo. Es una forma muy segura. Entonces cuando yo trabajo la artroscopía de codo, trabajo de frente, nadie me molesta, y fíjense que la disposición parece mucho a la artroscopía de una rodilla, ¿verdad? Otro elemento de importancia y seguridad cuando trabajamos en el decúbito prono o lateral, como es este caso, es esto, tener un vendaje elástico alrededor del antebrazo para no permitir que discurra líquido articular o líquido con el cual estamos trabajando hacia el antebrazo y genere un síndrome compartimental. El insuflado articular, otro paso para un procedimiento seguro, para mí es muy importante. Hay gente que no lo hace, pero la verdad es que está demostrado que cuando insuflamos la articulación antes de la cirugía, colocamos solución fisiológica, los nervios se van a alejar del hueso. y eso me da un rango de seguridad. Y lo otro interesante es que además genera resistencia para poder penetrar la cápsula con mayor facilidad, especialmente con el trocar inicial que colocamos. Aquí un videito de cómo estamos colocando el insuflado. Estamos usando el portal medio lateral entre el olecrano, el epicóndilo y cúpula radial. Fíjense que siempre pintamos las estructuras óseas sobre el codo antes de empezar la cirugía. Después el codo se puede distender y perdemos las referencias anatómicas. Entonces las estructuras óseas las pintamos, las dejamos marcadas, insuflamos la articulación. Después les voy a mostrar del lado medial cómo pintamos también el nervio cubital, que es muy importante. Bueno, y los portales, les voy a describir de forma general cómo ubicamos los portales, cómo los hacemos. Y los portales nos sirven para dos cosas: para colocar la cámara y tener visión articular, que es de fundamental importancia, y para colocar instrumentos de trabajo. Y a su vez los vamos a ir intercambiando. Los portales pueden ser anteriores o posteriores. Los anteriores pueden ser mediales o laterales. Y el posterior o posterolaterales, nunca posteromediales, porque está el nervio cubital en estrecha relación con el canal epitrócleo-craneal. O sea, los portales van a estar determinados por las estructuras neurovasculares. Por eso tenemos que saber dónde están para poder poner nuestros portales en zonas de seguridad, que son estas. Y todos los portales, en mayor o menor medida, pueden ser más proximales o más distales, dependiendo de nuevo de las estructuras anatómicas. El portal anteromedial, mucha gente empieza con el portal anteromedial, a mí también me gusta empezar mis artroscopías con el portal anteromedial. Usamos la epitróclea como referencia. Las estructuras de mayor riesgo acá van a ser el nervio cubital, que pasa por detrás de la epitróclea. Siempre tenemos que revisar que no sea un nervio luxable, así sabemos exactamente dónde está. Y por delante y más alejado va a estar el nervio mediano. Entonces podemos hacer un portal anteromedial directamente anterior a la epitróclea, o anteromedial proximal, de nuevo intentando de evitar lesionar el nervio mediano cubital, y de forma punteada, que tenemos que separarlo cuando hacemos el portal en piel, ramas del nervio antebráqueo cutáneo interno. Entonces tomamos como referencia la punta de la epitróclea, vamos hacia proximal, hacia anterior, puede variar entre 1 y 2 centímetros, y vamos a tener acceso a mirar todo el aspecto anterolateral del codo, cúpula radial, coronoides y parte distal del húmero. Entonces palpamos, sabemos dónde está el nervio cubital que está marcado, epitróclea 1 o 2 centímetros por delante a proximal, hacemos la incisión superficial en piel, y después hacemos una disección roma para evitar lesionar cualquier estructura cutánea. Tomamos el trocar, la articulación está insuflada, y apuntamos hacia la cúpula radial. Entramos. Una vez que entramos, sale el líquido que habíamos metido adentro, y empezamos con nuestra visión. Ahora vean que el codo está firme, está rígido, nadie nos molesta. Insuflamos la articulación, podemos ver bien cerquita nuestro, haciendo flexión-extensión, la punta de la apófisis coronoides. Hacia lateral con pronosupinación la cúpula radial. Y todo el extremo anterolateral del húmero distal, cápsula e inserción tendinosa lateral. Bien, el portal anterolateral, del otro lado, la estructura con mayor riesgo aquí va a ser el nervio radial, que después se transforma en nervio interóseo posterior. Usamos el epicóndilo como la estructura de referencia y podemos poner un portal anterolateral directo o uno más proximal. La tendencia es que a más proximal tenemos mayor seguridad de no lesionar el nervio. A mí me gusta hacerlo de adentro hacia afuera, es decir, una vez que estoy mirando desde el anteromedial, desde afuera colocar el anterolateral, y ahí les voy a mostrar. Estamos mirando de nuevo, como veíamos antes, el sector lateral del codo. Palpo con mi dedo, cuando palpo se abomba la cápsula, y coloco de afuera hacia adentro una aguja. Ahí está la aguja intraarticular. Fíjense que la aguja está justo por delante y por encima del epicóndilo lateral. Y después generamos el portal lateral. De nuevo, la incisión en piel es bien superficial y después trabajamos de forma roma profunda. En este caso estamos metiendo una punta a una halsted, si no podemos meter directamente con el bisturí con más experiencia, o directamente también el shaver, ¿no? En este caso abrimos un poquito el agujero que hicimos con la punta de la halsted, colocamos un shaver y empezamos a hacer el trabajo que queremos hacer. En este caso estamos sacando osteofitos de la punta de la apófisis coronoides y de húmero distal. Y una vez que terminamos con el trabajo en el compartimento anterolateral, y si queremos cambiar de portales, también hay formas de hacerlo de forma segura. Ahora les voy a mostrar. Aquí estamos sacando el osteofito del húmero distal. Pero fíjense que siempre está la cápsula distendida y estamos trabajando sobre hueso, nunca tocando la cápsula en este momento, y siempre que trabajamos con el shaver en el compartimento anterior, lo hacemos sin succión, ¿sí? Sin aspiración. Así no tenemos daño capsular. Una vez que terminamos de hacer el trabajo anterior, vamos a cambiar los portales, y en vez de sacar los portales y empezar de nuevo, apunto el shaver hacia la cánula, donde tenemos la cámara, y voy retrocediendo con la cámara, y adelanto el shaver adentro de la cánula. Entonces no necesito sacar los portales para perderlos, para intercambiarlos, digamos, ¿no? Avanzo con el shaver, con el trocar, uso una cánula de intercambio o un Steinman Romo, y cambio de lugar de los portales. Ahora voy a pasar a mirar desde el portal lateral hacia el portal medial. Y esa es una forma segura de cambiar los portales y seguir trabajando en el compartimiento sin perder referencia de las estructuras óseas, especialmente cuando el codo se empieza a inflar un poquito. El compartimiento posterior, por suerte, es más sencillo en cuanto a seguridad, porque el único nervio que tenemos que tener en cuenta aquí es el nervio cubital. Mientras estemos alejados del piso del canal epitrócleo-craneano, la zona medial del tríceps en sí, estamos seguros y podemos ir trabajando en toda esta franja, desde el portal posterior directo, uno más proximal, uno posterolateral o el medio lateral, estamos seguros. Inclusive aquí el uso del bisturí puede ser directo a través del tríceps hacia la fosa olecraniana o hacia el hueso. ¿Sí? Ahí hicimos el portal directo posterior, ahora estamos haciendo uno posterolateral por el lado lateral del tríceps, pero vean que siempre trabajo lejos del nervio cubital. Lo dejo aquí marcado, ya sé dónde está. Y accedemos al compartimento posterior, y enseguida podemos ver la punta de la apófisis, del olecranon, la fosa coronoide. En este caso era un caso con una osteocondromatosis sinovial múltiple, ahí le estamos sacando los fragmentitos. En el compartimento posterior podemos trabajar con mayor seguridad con aspiración con el shaver, salvo cuando estemos trabajando en el rincón medial. Este es el rincón medial, por detrás de esta cápsula va a estar el nervio cubital. Esta es la zona que hay que tener cuidado, en la zona posterior. Pero después podemos trabajar con comodidad mientras estemos cerca del hueso. Ahí sacamos todos los cuerpos libres. El uso de retractores es otro paso importantísimo en el procedimiento seguro. Así como cuando hacemos cirugía abierta usamos retractores para separar y para tener mejor visión y trabajar más cómodos, tenemos que saber usar retractores en la artroscopía de codo. Nos sirve para separar partes blandas y cápsula, pero además para trabajar con baja presión de líquido. Si estamos la artroscopía de codo la hacemos con manguito hemostático, entonces no hay problema, no va a sangrar el codo. Podemos trabajar con presiones de líquido bajas, así no generamos edema y que el procedimiento sea más complicado, ¿verdad? Aquí estamos haciendo resección de osteofitos en un paciente artropático, y fíjense que quiero sacar el osteofito acá, que está justo por encima de la fosa del húmero distal, y la cápsula articular se me viene encima, no me permite trabajar cómodo. Entonces en estos casos colocamos un portal lateral más proximal, cerca del hueso, y utilizamos cualquier elemento romo para separar la cápsula. Ahí entramos con el elemento, separo la cápsula articular, sin necesidad de aumentar la presión del líquido articular en el codo, y podemos resecar osteofitos con mayor seguridad y mayor tranquilidad. La planificación preoperatoria, quizás este punto tiene que estar antes de todo, ¿no? Pero es muy importante tener un mapa del codo, una tomografía computarizada, si es con reconstrucción tridimensional mejor, saber de antemano qué portales queremos usar y cómo llegar a cada uno de estos rincones que queremos llegar que les va a mostrar Alessandra mejor. Uno de mis maestros que me ha enseñado muchísimo artroscopía de codo, John O'Driscoll, él decía que antes pasaba aproximadamente entre media hora y una hora de la cirugía mirando la tomografía, teniendo ese mapa, ese registro en su cabeza antes de empezar a operar, para evitar cualquier complicación. Entonces, la suma de todos estos elementos hacen que sea un método sencillo y seguro para el paciente, pero todo esto lo más importante es conocer mis límites. Entonces, empezar con casos más sencillos a más complicados, a medida que me siento más cómodo con la anatomía del codo, que siento que puedo trabajar en un espacio libre y cómodo, voy avanzando. Mi recomendación es empezar con resecciones de cuerpos libres, después con resecciones de osteofitos, tenotomía en casos de epicondylalgia lateral, y así progresivamente ir avanzando, pero a medida que uno se sienta cómodo trabajando con seguridad en el codo. Bueno, espero que les haya sido útil esta presentación. Y los invito a todos a visitar ortofleximal.com, que tenemos procedimientos quirúrgicos paso a paso para que puedan disfrutar.
Muchísimas
Bueno,
gracias.
muchas gracias.
Juan Pablo, excelente presentación. Tenemos unas cuantas consultas, por favor.
Sí.
Aldo nos pregunta si lo hace con bomba de presión y si es así, ¿a cuánto?
Sí. Yo lo hago con bomba de presión porque estoy acostumbrada a hacerla, pero le pongo el flujo en 80, pero la presión, los milímetros de mercurio, entre 20 y 25. Muy, muy bajo. Lo único que dejo es que salga un chorrito de líquido para que distienda un poco la cápsula. Y a partir de eso no me muevo, uso retractores.
Perfecto, muchísimas gracias. Patricio Moggio, de Argentina, ¿qué diámetro de óptica utiliza?
La de 4 milímetros, la misma que rodilla y hombro, ¿sí? Eso es una pregunta que nos hacen con frecuencia. Hay que recordar que este es un procedimiento que es intracapsular, pero es extraarticular. Salvo que sea un codo inestable, nunca vamos a entrar entre los huesos, sino que vamos a trabajar por delante o detrás de ellos. Con 4 milímetros estamos muy bien.
Tenemos una pregunta de Víctor Naula. Dice, Luigi Padersini, antes de iniciar la artroscopía de codo, realizaba transposición del nervio ulnar. Si se sigue utilizando o ya no.
No se hace de rutina, sí se hacen para los casos de rigideces de codo que hayan estado mucho tiempo con menos de 100 a 90 grados de flexión. Mínimamente hay que descomprimir ese nervio o transponerlo si es necesario, pero si uno lo transpone, tiene que saber exactamente dónde está si quiere hacer una artroscopía de codo después. Cuando hay un nervio transpuesto previo a la artroscopía de codo, o no se hace la artroscopía y se hace directamente la cirugía abierta, o hay que ubicarlo con ecografía, o hay que disecar, hay que saber dónde está.
Perfecto. Después Luis Pedro Carranza le consulta el uso de retractores mediales.
Sí, se pueden usar mediales también, ¿sí? Teniendo los mismos parámetros de seguridad. Recuerden que del lado medial tenemos portales anteromediales clásicos, anteromediales proximales también. Se pueden usar, pero por lo general yo uso el lateral porque me resulta más cómodo y con uno habitualmente es suficiente.
Tenemos otra consulta de Ever Maquera. Si tuvo alguna complicación neurológica durante la realización de la artroscopía y cuáles fueron las más frecuentes y cómo las solucionó.
Mira, por ahora, por suerte, no tuve ninguna complicación neurológica. Sí tuve 2 casos míos de rigideces importantes, que cuando empecé la artroscopía el espacio para mí era muy cerrado y decidí pasar a cirugía abierta previo a tener el riesgo de hacer una lesión neurológica. Con eso me cuido mucho. Por suerte no he tenido mi caso.
El tiempo quirúrgico más o menos estimado y el uso de torniquete.
Sí, el tiempo quirúrgico nunca va a ser más de 1 hora y media justamente por el tiempo de torniquete. A mí no me ha tocado tardar más que eso.
Perfecto.
Pero bueno, por eso es muy importante la planificación preoperatoria, porque el paso tiene que ir muy fluido, porque uno sabe que tiene el tiempo límite del torniquete.
Perfecto, Juan Pablo, muchísimas gracias. Excelente presentación. Ya no tenemos más consulta. Por favor, pasamos con Eduardo y Juan Martín para que sigamos con la doctora Alessandra.
Hola a todo el mundo. Yo hablaré en English. I'm sorry. but I'm trying to learn Spanish, but I'm not so good now. I saw from the talk of Dr. Simone. Can you see the presentation? Can you hear me? Can you see the presentation?
Se ve, doctora, perfecto. Adelante, se está viendo,
Okay.
se está viendo muy bien.
Okay. So I see from the presentation of Dr. Simone that we think that same things. So we have the same kind of approach to the elbow arthroscopy, fortunately for you. So Dr. Burman in 1931 stated that the elbow was unsuitable to the arthroscopic exploration. But after that, O'Driscoll more recently explained us, if we know the anatomy, if we know where the nerves are, we know that where the nerves are not, so we are able to explore arthroscopically the joint of the elbow. We already seen the portal with Dr. Simone, so we know when we work in the elbow, we know that we are watching like from a window, so our portal is the window, and you can see the opposite structure respect to the portal. Of course, we can see just the intraarticular portion of the elbow. So the capsule, the cartilage, and the bone, and we can see very well the ligaments, and then we see this after in the next presentation. About the medial portals, we have the choice to make two kinds of portals. We can stay more proximal if we need to work in this area. In most of the case, we approach degenerative problems or osteoarthritis or stiffness. So we have to use this portal to release the capsule. We have to remove the osteophyte bony spurs. But when we have to deal with a fracture of the coronoid, I prefer to make a more distal portal, more or less at the level of the rim of the joint. In this way, we are able to manage in a better way the fragment using retractor or other instrument. If you make this portal, you have the bump of the trochlea, so it's very difficult to manage the fragment. And we already see the posterior portal. I would like to stress that it's very important to go here in the medial gutter to check for a look for loose bodies, potentially loose bodies. We know that behind the capsule, we have the ulnar nerve. And this is the central area of the posterior side. And we normally use the posterolateral portal to see the olecranon fossa, but in some instances, if you have a bony spur around the olecranon, you are not familiar with the shape of the olecranon, you can put the scope here, then you can see the symmetry of the olecranon. It's easier for you to understand the shape of the olecranon that's removed. And this is a very important point for me to reach this area. So you have to slide along the lateral ridge of the olecranon, then you have to turn the scope anteriorly, and you can reach this area. This area is, I suggest you to try to make this kind of movement every time you have to treat an elbow arthroscopically, because it is a tough area. Most of the cases are full of soft tissue, the synovitis, sometimes you can find osteophyte. If you are able to reach this point easily because you are used to do it every time, it's easier for you. On the other hand, if you do it once in a while, it could be difficult. And in this area, you see the proximal radial ulnar joint, the radial head, the capitellum from the back. And if you turn the scope medially, is the only way to see inside the ulnar-humeral joint. So you extend the elbow a little, you supinate, and you open the ulnar-humeral joint. If the elbow is unstable, you can even make the so-called drive-through test, so you can push the scope inside the joint. So if you stand a little, you stress, you can go inside the ulnar-humeral joint. This is the only way to reach a potential damage of the trochlea, like an OCD of the trochlea. You can see the bare area of the olecranon. And if you are able to pass through the joint, it means that the elbow is unstable. So it has also a diagnostic value. So the steps that Dr. Driscoll told me about the beginning of the arthroscopy is first get in, establish a view, create space in which to work. So get in, establish a view. So in some instances it's very easy, some other times it's very difficult. So we know already from Dr. Simone that we start generally with an injection of 20 cc of saline liquid. I use generally the posterior portal, but it doesn't matter. You can use both the soft spot portal, the posterior portal. And once again, we start, as Dr. Simone told us, from the anteromedial portal. It's very important just cut the skin to avoid the damage of the cutaneous branches of the nerve. But the most important thing for me here to teach you that stay far from the bone. I mean, when the entrance point of the portal, you don't have to be too close to the bone. In this way, you are not able to put in the right position the instrument. The instrument must point against the bone from the anterior to posterior. And the direction of the instrument is very important, because if you put the instrument in this direction, you can damage the nerves. On the other hand, if you enter in this way, you have this direction, you are safer. And I agree with Dr. Simone, we use the retractor instead to put very high pressure on the pump. We use around 30 millimeters of pressure of the pump to avoid the compartmental syndrome. And after making the first portal, so we said the anteromedial portal, we go on making the second one, is the anterolateral portal. We use a needle, as we saw previously, but in very difficult cases, you can use an opposite technique, the inside-out technique. So you use the switch stick, you can cut the skin and then pull the switch and stick and use it as a guide for the shaver. In some cases where we have to deal with a very stiff elbow, we can have some trouble to find a way to see the joint. So my suggestion is try to stay inside the joint and feel absolutely, you have to feel the bone. This is very important. Not start cutting something if you're not very careful, you're not sure that touching the bone. In some instances, you can see, you are not able to see the corner, your anatomical landmark, you just see white tissue. So in those cases, I go out, I restart, I use the retractor before making the portals, for example, and I use the scope like a periostal elevator to try to find a way to touch the bone. And after that, you have to start to releasing, you have to start to create a space in which to work. So first, you can remove the synovitis, and we generally start from the entrance point on the portal. So we release the soft tissue on the supinatory crest, what we are doing now. This is most of the case the procedure that we do when we have to treat a lateral epicondylitis. So we open the capsule, we release the supracondylar crest. In this way, you detach the anterior capsule from the humerus, so you open the space. And using retractor, you can see that very gradually, you can have a bigger space in which to work. This is fundamental, because in this way, you can increase the distance between your instruments, your cutting instruments, and the capsule, and so the nerve. It's very important to know the internal markers, landmark for the nerve. The radial nerve is exactly in front of your radial head. So from behind, from inside the joint, you know that the radial nerve is in the middle of the radial head, behind the capsula. And another step very important is try to remove all the loose bodies. Most of the surgeons tell us that the loose body removal is an easy procedure. I don't think it's so easy like people think. I think that sometimes you need to grab your your loose bodies, and the loose bodies flop around your joint. So you have to fix it with a needle. This is useful as tips in the posterior side. In the anterior side, sometimes if you use a big grasper, you open the grasper, the fluid, push the loose body in the grasper. So it's another nice trick to use. It's very important to make the capsulectomy after the bony work. This is because when you make the bony work, you have a lot of debris. And if you have already done the capsulectomy, you can increase in this way the pressure of the forearm and increase the risk of compartmental syndrome. So after getting establish a view, remove the loose bodies, you have to do your bony work. And another question that most of the people do is, how can I understand how much bone I have to remove? Well, one suggestion could be that you go on removing the bone until you can see once again the soft tissue. The soft tissue in the olecranon fossa is the original periosteum of the native coronoid fossa. So in this way, you can understand when you finish to remove all the extra bone. And after that, as final steps, you can do the capsulectomy. So we can discuss about the capsulectomy when you have a loss of extension, just a 20, 30 degree, I generally do just the stripping of the capsule from the bone. When you have a bigger contractor in extension contractor, you have to do the capsulectomy. Now we are making the capsulotomy. It means we are just cutting, making a transfer cut in the capsule. And this technique is called bite and peel. It means that you grasp the tissue and pull the tissue from the brachial muscle. After that, you can go on resecting all the capsule. This is the most risky procedure in elbow arthroscopy. So you don't have to use the suction in this step. You have to be very careful. You don't have to cut the muscle. Of course, you are safer on the medial side because you have the brachialis that protect your medial nerve, but on the lateral side, you have a risk to damage the radial nerve. So you have to be very careful. You have to detach just the capsule from the muscle, not to cut inside the fibers of the muscle. This is a very important point. Going back to this area, I told you this is the most difficult one because it's very tight, and sometimes you have scar tissue, and sometimes it's very difficult to reach the radial head from the back. So one trick could be use the switch and stick and push it until you feel the bone and you feel the radial head, and then you put the scope under lying on your switch and stick. And generally, if you put the working instrument like the shaver in this area from the soft spot portal, you start to removing all the synovial tissue. You work in this way. And the aim is to reach the radial head. After reaching the radial head, it means that you remove all the tissue. In this way, you can see very well the radio-ulnar proximal joint. You to check the posterior insertion of the radial head, the annular ligament, sorry. You can also release, if you have a contracture in pronosupination, the tissue in the back of this joint. But I like a lot making these cross portals. If you can see from the proximal anteromedial portal and use your instrument from the back. So you see anteriorly and you work from the back to the front. In this way, you have the advantage to be parallel to the radial head. And this procedure, this step is useful, of course, if you have a synostosis or you have a deformity of the radial head. So you can be parallel to the joint. You can slide here in this area. So it's very useful and is the only way to release completely the radial head, because if you enter from the anterolateral portal from this direction, you are not able to go here. If you watch anteriorly and work from the back to the front, you are able to work in this area. And now we went back on the posterolateral portal and the soft spot portal to release the posterior side. Same tips as if you want to make a resection of the radial head for the same reason. You are parallel to the radial head and to the joint, so you can make a very nice resection, very symmetric, working from the back and watching from the front. For the OCD, same concept, we work in this area. Most of the case, the OCD is posterior on the capitellum, but you can use two portals, parallel and very, very close one to each other. You can use the same portal, you can make two portals. In this way, you are able to see the capitellum from distal to proximal, and you can make a debris or microfracture, whatever you want, but you can see very well in this way. The last option, there was a case of HO around the radial head. It's very important in this case of HO to try to understand the relation between the HO and the nerves, particularly in this case of the radial nerve. As you can see, the patient has a pre-op good flexion extension, it has a loss of supination. So after watching carefully the CT scan, we decide to remove the ossification with a through arthroscopy. And same concept, in this case, we have a high risk of injury of the radial nerve. So we have to detach the soft tissue from the bone. So we're watching from proximal and anteromedial working laterally. And we have to use the suction just for a few seconds when you have to suck the debris because you are not able to see. And the radial nerve is here. We release the capsule. So you must be very careful not to wrap the tissue on the side of the capsule, obviously. And after that, we can check, we decide to keep the implant inside because it was fine and we didn't have any kind of chondropathy. So the conclusion is the same concept of the Dr. Simone is not try to be very careful when you approach arthroscopically an elbow and ask to somebody else with a major expertise to help you if you are in doubt. Don't go behind your limits. Thank you.
Bueno, muchas gracias, Alexandra. Excelente la presentación. Un gusto de volver a verte y a tenerte en nuestra asociación. Y bueno, vamos a abrir el cuestionario de preguntas para los participantes. Juan Martín, no sé si quieres.
Bueno, gracias, muy buena la presentación. Hay una pregunta sobre si en un caso de una triada desafortunada o terrible de codo, ¿qué indicas, si tenés indicación de artroscopía o de tratar de resolverla de esa forma?
In the next talk, we're going to speak exactly of this, of the fracture, arthroscopic approach to the fracture. So we're going to talk. Okay. I can tell you now that I like to approach arthroscopically. It's a terrible trial, but just the easiest case, not the big terrible trial. So small fracture type 2 of the radial head, small fracture type 1 of the cornoid, no major instability because it becomes very complex. So just the minor cases.
Y en estos casos que mostraste de rigidez, ¿cuál es tu principal indicación o cómo llegan, qué tipo de rigideces? ¿Postraumáticas, osteoartritis primaria? ¿Tu experiencia cuál es?
I can tell you, I push a lot the arthroscopy because I really like it. I think you are very precise with the arthroscopy, sometimes more than open, because you can approach three-dimensionally the elbow, medial, lateral, posterior, and with the open access, you choose one incision, lateral, medial side. So you are very, very three-dimensional. Said that, I don't have many contraindication, except the anterior submuscular transposition of the ulnar nerve. I did some arthroscopy in stiffness, even after subcutaneous transposition, because I look for the nerve, I see the nerve, I retract the nerve, so you can put the scope. And I think we have to separate the stiffness of the elbow in two big groups, the degenerative and the post-traumatic. The degenerative cases are easier. You have a lot of space inside the joint, is not very difficult. On the other hand, the post-traumatic could be very difficult. So probably it's a different way in if you have a beginner in this kind of surgery, you have to have in your mind this concept. So it's better to begin with the degenerative problem instead that post-traumatic. In post-traumatic, even if you have a small loss of joint motion, you can have a lot of tissue inside the joint. It could be very, very difficult to get in and establish a view. Dr. Simone, do you agree?
Se escucha una interferencia.
Sí, ya se liberó.
Bueno. Hay una pregunta. In which cases do you indicate radial head resection?
So not in traumatic patient, never. But in some cases of degenerative problem, if you visit the patient, examine the patient before the surgery, and the patient complains of the radial humeral pain, and we generally do like a compression test. We ask to the patient to push in supination and pronation against resistance. If the patient complains about the lateral pain, it means that probably the pain of the joint are related to the bruise of the radial head. Of course, most of the cases that they complain about pain, they also have a CT scan that show you gels and arthritic joint but are very selected cases. I remember I've done a few cases of the resection of the radial head. So just in a very sharp pain on the lateral side in osteoarthritic elbow that you have to approach with a release and osteophyte removal, because in this way you increase the instability. So very, very often you see the arthritic joint on the lateral side, but the patient is asymptomatic. So be very careful not to cut a radial head if the patient is asymptomatic on the lateral side, because you risk instability.
It's a question of André Leg to both speakers. Are you releasing the cubital tunnel by arthroscopy?
You mean the release of the nerve?
Yes.
I don't do it because I think it's risky. Sometimes you waste a lot of time. So if I have just to do the ulnar nerve neurolysis, I do by open with a small incision. If we have to do the neurolysis in association to the arthrolysis, I do first the nerve, isolate the nerve. I don't transpose rectilinearly the nerve. I just make the neurolysis, and then I do all the surgery. And after, at the end of the arthroscopy, I use that small incision to resect the posteromedial capsule and to check if there's something like a small burst and osteophyte on the medial side of the joint. But I don't like to do it arthroscopically. I don't know if Dr. Simone agree with me, but...
Juan comenta que está teniendo un problema con su micrófono. Justo no sé, Rodrigo, si... Juan Pablo Simone.
Ahí estoy, ahí volví.
Ahí está.
Sí, lo mismo, no hago la descompresión artroscópica del nervio, también si la tengo que hacer es un abordaje mínimo, y también sirve de paso para las contracturas en flexión para liberar el fascículo posterior del ligamento medial y se hace en el mismo acto, pero no hago trabajo en esa zona con artroscopía.
No, I agree with you.
Y Alessandra, en esos casos de Juan comentó de una rigidez importante, previo a la cirugía justamente con el nervio, con el cubital, ¿en qué casos hace un release previo o no?
So in the past, the indication were if you have a contractor no more than 90 degrees, or if you want to recover more than 40 degrees, or if you have a previous neuropathy. but now the indications are wider. I mean, the indication includes also a loss of just 30 degrees of tension. I talked about this topic with Dr. Druisco. He started to make the neurolysis, even in case just of the 30, 40 degrees of contracture in extension with full flexion, because it seems that the floor of the area of the ulna can have many adherences with the nerve. So it's better to release the nerve. In my experience, I do it in any contracture.
Okay.
I don't do it, of course, in the trauma. In the trauma, I do it just if I have to repair the medial side, I mean the medial ligament.
Bueno. Ok. Muchas gracias. Bueno, continuamos. No sé, Rodrigo, ¿te parece con la otra presentación? Okay.
Okay, I'll go on. Well, let's go to, okay, let's talk about fracture. Can you see the presentation?
Yes.
Okay, thanks. So I'll answer to the question about the terrible trial. So we know that arthroscopy is...
Sorry, Alexandra. Now we are seeing a list of presentation, not the PowerPoint.
Well, okay. Sorry. Sorry. Okay. I can't find the Zoom now. Zoom. It's here. Oh, wait a moment, sorry.
Yes.
Ok. Allora, qui ci siamo. Così. Okay, I think I'm done. Perfect.
It's okay.
Okay, sorry about that.
No
so we know that elbow arthroscopy is safe even in fracture, but we know we have to stress once again the pressure must be low, and we always have to try to understand the pattern of instability. About the radial head, I suggest, and the literature support me, that we can treat arthroscopically the type 2 fracture of meson and ligament and a periosteum continuity. This is why if we have a lesion of the lateral side, I routinely do it by open approach, because you have to repair the ligament. You just have to cut the skin, you can approach very easily the joint. So the arthroscopy for me mustn't be just a virtual technicism, must give you some advantage. And this is a case of type 2 with also an involvement of the neck. But the fracture of the neck was very stable. So we start generally in the lateral side position with a proximal anteromedial portal. So the advantage is, of course, we can remove all the fragment of the cartilage. Another very important point, when you go inside the joint, you have to check the relation between the capitellum and the radial head. If you see the contact is good, like in this case, it means that the ligament, the lateral side of the ligament is fine. You see in another case when this distance is very increased, it means that you have a lesion of the lateral complex. And as you can see here, there's no damage of the annular ligament. Sometimes we use the annular ligament as a way to keep a reduction of the fragment. So I used in my experience in different instruments, the retractor, and I like to use the chondropic because it's pointed, so you can go inside the fracture, you can turn it, and you can push it back in its position. So we put 2 screws just to fix the fragment. And then we, as you can see, the advantage of the arthroscopy that you don't have to cut the annular ligament. You can leave it intact. And we can put the screw in different position from the back to the front, or from lateral, from a lateral position. We use normally the cannulated screw in titanium 2.4 or 3.0, and we can put it in different shapes, but in my experience, I prefer to put it from the back to the front. We can see in the other slide that we can put the screw in other position, and you have to check arthroscopically when you put the screw the compression of the fracture. And after the fixation, you check the stability of the fragment, and you check once again the contact between the radial head and the capitellum to be sure that the instability doesn't exist. But we generally do the test under amplioscope before starting with the surgery, because as I told you, the indication to open or arthroscopic approach is related to the condition of the status and of the ligaments. This is the follow-up. And from a cosmetic point of view, it is a very good result. As I told you, we can use different shape and different approaches. We can watch from anteriorly and put the screw from an anterolateral portal, or we can watch from the posterolateral portal and put the screw from the soft spot, as we did in some cases, or we can just use the annular ligament as a way to keep the fragment reduced. So no putting screws. I made this case I like to show you because I think it's a new frontier must be explored. In a pediatric fracture like this, we know that we have many techniques, percutaneous fixation or metazo technique, but if you use the arthroscopy, in this case we used the scope for the wrist, so the smallest one, you can see very well the cartilage. As I told you before, you understand the dislocation of the fragment because the distance is huge with respect to the normal anatomy. You keep the annular ligament intact. We are hammering with the chondropic to putting back the radial head in the right position. And then because the tendency of the radial head going back down, we put key wire with a mechanism lever to keep the radial head reduced. And about the coronoid, we can treat arthroscopically these 2 kinds of fracture. The type 1 is related to terebrotide, and type 2 or anteromedial fracture related to the posteromedial. These are 2 different kinds of the instability. So the posteromedial instability is related to a mechanism that's a valgus compression and supination mechanism. Is the mechanism related to the most of the cases of the dislocation of the elbow. And we started, this was my first case of terebrotide. The indication was given by the presence of this fragment in the lateral gather. So we removed this fragment, and then we did osteosuture. We transosteal suture of the coronoid because the fragment was small. In this way, of course, you don't achieve a very strong fixation, but it's like an anterior capsulodesis of the coronoid. Most of the cases are an evolution in a non-union or in fibrous union. This is the follow-up of the patient. We repaired at that time the lateral complex with an anchor through a small incision of 2 centimeters. And after that case, we went on, look at the distance. Now we can see very clearly that we have a lateral instability. So we removed this fragment. We fixed the fragment of the radial head with a screw from the back to the front. We use this needle as landmark to understand the direction at the key wire, You must be very careful putting the key wire for the guide of the screw, because if you penetrate the soft tissue on the front, here you have the radial nerve. So it's very important to hold the key wire with a snap to avoid the penetration of the key wire in the tissue, and to avoid to lose the direction and the tunnel made by the drill for the screw. Now we switch the instrument. We are making now once again the osteosuture of the coronoid, because the fragment is too small to be fixed with a screw. We like to make 2 parallel tunnels. Then we pass a knot. We generally use a resorbable wire like a PDS. We pass the knot in the capsule behind the coronoid. We don't pass through the fragment of the coronoid, because I am aware to break it. And then you pull the suture. And after making the coronoid and the radial head, we fix the ligaments with a small open incision, put in an anchor, because in this case the surgery is a little bit long. In the posterior medial cases, we have a different pattern of instability. We have the varus, so lateral complex torn, and the buttress of the coronoid, the medial side of the coronoid is broken. And so you have 2 problems to deal with: the problem of the lateral ligament and the problem of the coronoid. Most of the case, we have also a posterior bundle of the MCM torn, but in many cases, we didn't repair it. So the problem about this fracture is the treatment. We have 2 different kind of schools. The Mayo Clinic school tend to treat this kind of fracture. The Spanish school tend to not treat it, but we have a couple of points that are very important. The surgical indication is done by two tests, 2 different features. One is the CT scan. In the sagittal view, if you see the incongruency, it means that the elbow is unstable, so the fracture has to be treated. And the other important test is this one, is the varus test. So you put the arm, the shoulder 90 degree of flexion, and you stress in varus. As you can see, the ulnohumeral joint is opening. This is called the drop sign. It means that the elbow is unstable. On the other hand, if you make this kind of test and you see a congruency along the wall arc of motion, it means that the elbow is stable, and in this case, you can treat it just with a brace in a conservative way. Another case, 35 years old, anterior medial fracture. Another very important point, you have to study the fracture with the CT scan, because if you see an involvement of the sublime tubercle, you have to make the open incision, because you can control a fracture that involves this area. This area is very important. We have the distal insertion of the anterior bundle of the collateral ligaments, so you can treat arthroscopically just the fracture that involves the tip and the anterior medial side, just to the sublime tubercle. So going in the details of the technique, as I told you before, we like to make a more distal port on anterior medial. We clean the fracture. We generally are able to treat this patient in 5-7 days. I think it's a good window of treatment, because you don't have bleeding, you don't have fibrotic tissue, so it's a good compromise. You can manage very well the fracture, as the aim is to achieve an anatomic reduction. You have just to push the coronoid against the trochlea. The trochlea is like a template for your coronoid, and you don't have to detach the anterior capsule. So you open the fracture, you put the key wires as a guide for your cannulated screw. We prefer, if it's possible, to put more than 1 screw to avoid the rotation of the fragment. Then we work in this way, from the back to the front with the amplioscope around us. And then you keep the reduction. You can use retractor, chondropix, and you use this, then you make the measure of the length of the screw. You have to check if the key wire is intra-articular or not. I'll show you later on the x-ray that you have to use a direction from distal to proximal to avoid the joint. Then after taking the measure, you have to go a little bit further, hold the key wires. This is very important to avoid the anterior migration, because we have on the front of the corner, we have the brachialis, and then we have the median nerve. And you can lose your key wires if you don't hold it with a snap or a cocker. And then we put the screw, we check the stability of the fragment to give a correct post-op protocol. And after that, in the first cases, we used a small incision, as I told you before. This was my first cases. The patient complained about the hardware, obviously, so we changed our technique. Now we buried the screw, making 2 drill perforation, and we didn't have any other problems in the other cases. You can even deal with more complex fracture like this one. You have 3 fragments, you can put 3 screws. It's very important, the diameter of the screw. In this case, we use 2.4, and the technique is the same. But as you can see, now we are burying the screw, and the direction is not this one. It's risky for the to go inside the joint, but if you use this kind of direction, you are perpendicular to the rim of the fracture, and you can avoid the joint. After these cases, we started with arthroscopic repair of the lateral ligament. We are still talking about posterior medial rotatory instability. In this case, the lesion of the lateral complex is minor respect to the posterior lateral rotatory. So we start generally with a coronoid. Of course, we do the test under amplioscope, and now we are watching in this area, in the posterior lateral gather. So we put a PDS from the epicondyle to the soft spot in the direction of the lateral ligament. So we pass another wire from the supinatory crest to the soft spot. So we have 2 wires now. We join with another 2 wires. We pull this wire, so we have just 1 wire, and we use as a guide this wire to have 2 wires. Then we retrieve the 2 wires here, and we tie the knot. As you can see, the effect of the knot, we have we are recovering the space between the capitellum and the radial head, with not a gap anymore. And this is a follow-up. This is the original technique described by Dr. Marinet in 2016. And now we are starting to repair with the anchors, the ligament. So if we see a clear detachment of the ligament from this area, we are watching from the posterolateral portal. We can put a guide for the anchors. In these cases, we use the alt suture anchor. Then you have to retrieve your suture passing from distal to proximal. We use the clever hook. This is a technique described by Dr. Félix Savoy. So you retrieve the first wire, then the second one. So we're working in this area. We're passing from here to up here. It's not very easy to reach this point. You can use the retractor to have more space. And then after closing the knot, you can decrease the space and recover the stability on the lateral side. This is the ligament reattached to the original insertion. I like to go back in the front after making that to check with the probe that I recovered the normal relationship between capitellum and the radial head. I like to go back anteriorly and check every time. So about the coronoid, we have in the literature a few experience. We did 41 patients, 21, now we have done more than 30. And we try to treat all the anatomical lesion and try to fix, in most of the cases, the fracture of the coronoid we screw, because we like to have a stronger fixation to allow a very active motion after a couple of days. The maps in this case is pretty good. We had just a case, a complication was related to ulnar neuropathy post-op. The patient complained about the tingling and flexing the elbow behind 90 degrees. So we release the nerve and we treat the stiffness. It was just 1 month from the surgery. With manipulation, we solved the problem. We never had the HO. And to finish the capitellum fracture fixation arthroscopically, we have just a few cases in literature. We started with this technique, but it's very important, the selection of the patient. You have to choose the patient with a single fragment fracture with an intact lateral complex. If you have a torn ligament, as I told you for the radial head, I suggest I generally prefer to do it with an open approach because we have to repair the ligament too. And so it's a very long surgery if you have to make it arthroscopically. This kind of procedure is pretty difficult, I think, because we have a displaced fragment very big. So it takes a few minutes to try to recover the normal relationship anatomically speaking. But on the other hand, you have the advantage that you can see very well. If you had to treat this fracture by an open approach, you have to detach the extensor muscle, of course. You have to try to avoid to detach the ligament. But if you do it arthroscopically, you can keep all the soft tissue intact. We are used to use many different kind of instruments. There are no dedicated instruments. And after working from lateral, we switch the instruments so we can check from the medial side and the lateral side the reduction. As you can see, the reduction now is good. And then we fix with a percutaneous fashion the fragment with a 3-screw. We watch with the amplioscope to understand the entry point, and we check with the scope to avoid the penetration of the screw. These are the x-rays and the follow-up of the patient. She was very fine. After the first check, she didn't come back for the other checks. For the post-op management, of course, we have to decide our protocol related to the kind of fixation or the quality of the fixation of the ligament that we repaired. Of course, we try to keep the arm elevated for the first 2 days. After that, we started with a motion. We like to allow active motion because the secondary stabilizer of the muscle. We keep the brace for 30 days, and we explain very carefully to the patient to avoid the barrier stress. It's very important. Mainly in the posterior medial rotatory stability. We use generally the indomethacin as prophylaxis for the HO for 3 weeks. And so to finish in the presentation, I will stress once again the importance to understand the pattern of instability. So when we bring this kind of patient in the OR, we just, every time we start with an amplioscopic control to checking the ligament, so you can decide if you feel comfortable to approach it arthroscopically or not. You have to decide the position of the patient. So it's very important to have the clear in mind which kind of structure you have to repair. Thank you.
Bueno, muchas gracias. Muy buena presentación. Con respecto, a ver, tenemos algunas preguntas. Bueno, hay una pregunta, sí.
See, I see I use very often the indomethacin, even in fracture, and more or less every time after the arthroscopy, for 3 times a day for 20 days. And of course, he has a function as an analgesic function too. So I currently use the indomethacin.
Bueno, entonces indometacina por 3 días, 3 veces por día. Muy bien. Son muy interesantes esos casos de fracturas más complejas, ¿no? De cúpula de radio proximal. ¿Cómo maneja el control radioscópico y el setup de quirófano? ¿Hacen la artroscopía con el equipo ya colocado o cómo lo
We
va?
generally start the arthroscopy on itself. And then if we have to use the amplioscope, as we do normally, we put the arch in this way, così.
Sí.
And they have to turn the amplioscope and put it in this way. In this way, you can work with the instrument, lateral and medially, and the instrumentator, the other people of the equipe can help you. Other surgeons prefer to have the C-arm around you, from the back to the front, but in this way, you can't move. Yes. Anybody can help you. So I prefer to put it in this way. I think it is nice. Unfortunately, we have a big one. It is not very useful. Somebody else have a smaller one, so it probably is better, but I prefer to put it in this way.
Ok. Ahí está viendo, hay otra pregunta, no sé si le gustan los tornillos bioabsorbibles en OCD cases.
OCD is a huge chapter.
Sí, es muy grande, un tema, digamos, hay casos puntuales, ¿no?
We do, it depends of the site, depends on the size of the fragment, it depends on the site of the lesion. So we studied OCD with MRI, but also with CT scan. CT scan is more important than MRI. They give you an idea of the wall of the OCD. So if we have a good wall, or if you are not able to refix the fragment, so the CT scan is very important. Normally we use more than screws, kind of technique is called an umbrella. So you can do it both by open or arthroscopic approach. You have to make a perforation in the center of the fragment, and you retrieve with your PDS wire, and the PDS wire can hold the fragment. Or you can make a cross constructor of the PDS. So instead to use the screws inside the fragment, you can use the PDS that surround your fragment and keeping in contact with the wall or the hole left from the OCD fragment. So we don't use normally screws, we use the PDS if we want to fix the fragment. Yeah.
Okay. Respecto a esos casos de lesiones ligamentarias, ¿tenés algún tiempo para pensar en la reparación o pensar en la reconstrucción? No sé en qué momento te llegan los pacientes para el tratamiento quirúrgico. ¿Algún tipo o tiempo para pensar en suplementarlo con injerto de tendón?
You mean in acute or chronic cases?
Chronic, digamos, o cuál es el tiempo justamente para considerar acute or chronic cases? To consider one or another.
I generally prefer, if it is a major chronic instability, I use a graft. I go by open. I don't recall to never convert from arthroscopy to open to reconstruct the lateral side. If I see is a minor instability, most of the case I use the barrier technique with a kind of shortening of the ligament with a PDS. But if I know it's a huge instability, I prefer to make a cochlear incision, a graft. So in most of the case, I decide before the surgery. And in acute cases, the limits is most of the case is around 20 days. 20 days. Okay. If you can use the patient tissue on another bed, but it's very difficult to tell you exactly the right time. But in acute cases, we repair. I never use the grafts in acute cases, of course.
Resumiendo, la doctora dice que toma 20 días aproximadamente para definir si es agudo o crónico y para definir una técnica abierta con reconstrucción o ir a la reparación que mostró en forma aguda. Edgardo, ¿no sé si tiene alguna pregunta?
El doctor Osvandrés está haciendo una pregunta ahí, Juan Martín.
Sí, yo quería preguntar si siempre utiliza el gesto de protección para que no se corra el Kirchner cuando introduce el tornillo, con la pinza, ¿no?
Con la protección con una... No ho capito.
La protección de agarrar el Kirchner para que no se deslice.
Siempre. Es mucho importante. I think because I'm making a lot of cases, every time I have the tendency not to use it, but every time, stop, do it. Because if you lose the hole, it's a tragedy. You have to, because in the back of the ulna, if you have to fix the coronoid, we make a small incision like this, is a ½ centimeter. So if you lose the elbow can be swelled because the trauma, because the arthroscopy. If you lose that hole, you can waste a 5 minutes to refine the hole. So it's very important to hold it, I think.
Okay, thank you.
Aquí preguntan si ha usado, hay algunos papers recientes de uso de celecoxib en lugar de indometacin, si tiene alguna opinión sobre eso.
We keep going on with the endometacin. I think it's just our custom. I don't think, claro. But I'm sure that the reason of the HO is a lot more complex. I think is related to many other factors if we are talking about the HO, particularly to the aggressivity of the surgeon, to aggressivity of the physiotherapy, to the presence or not of dislocation, to the length of from the trauma of the time that you go in with the patient in the OR, the many days that are. So there are many other factors for the HO. I think it's not just a chemical problem.
Y luego, si mantiene el codo en extensión o elevado en el posoperatorio y por cuánto tiempo en estos casos de fracturas.
Yeah, we normally put the elbow elevated, as I told in a slide, for 2 days. This is the average. Most of the cases are doing this way, even for trauma and elective surgery.
Y en esos casos de rigidez mencionó que usa bloqueo, sí. ¿No? ¿Qué tipo de bloqueo? ¿Pectoral o...?
Our anesthesiologists use the interscalenic of a supraclavier block. Infraclavier block is the favorite one because you have less risk of lose the cathetering. So in the most complex surgeries, we prefer to make the block. Now they put a little bit of an injection of local anesthetic to have an immediate analgesic effect on the arm after the end of the surgery. So we don't check the status or neurological status. But at the beginning, I suggest you to put the catheter in, don't inject anything, then make a general anesthesia. After that, check the neurological status and then inject the local anesthetic. It's better for your
para control.
To know if you are damaged in the nerves, not. But after a few cases, you can start to inject this something. Is the best way to approach a patient.
La doctora dice que prefiere dejar el catéter, controlar el control, hacer el control neurológico y luego hacer el anestésico para hacer un buen control. Y después, ¿cuántas veces por día hacen digamos, el paciente está anestesiado? ¿Lo van chequeando varias veces por día para movilizarlo? ¿Cómo manejan ese
we keep the catheter for a couple of days, for 2 days. So we, in elective surgery, we use like this Statue of Liberty position, and we leave the patient, after 2 days, we leave the patient free. We use CPM machine with the catheter in, but more or less we keep the catheter in 2 days. Because the patient after 2 days are discharged, they have the indometacin. Generally they don't complain a lot about the pain. In post-traumatic patient, after 2 days, we start with a physiotherapy. We we leave the catheter for 2 days, and then we use the brace. We go on with the indometacin, obviously. So generally 2 days of catheter.
Okay, 2 días de catéter entonces. Bueno,
Juan,
no sé, Rodrigo.
Una pregunta. Quedó una pregunta interesante de Luis Pedro Carranza con respecto a las... A ver, por un lado diferenciamos lo que es la osificación heterotópica y las calcificaciones, como dos entidades totalmente distintas. Pero yo considero que él se refiere a las osificaciones heterotópicas, tanto Alessandra como Juan Pablo, frente a una osificación heterotópica instalada, que realmente es una pesadilla. ¿Cuál es su proceder?
Well, we can treat arthroscopically the ossification, but there are some very important points. We have to study the relation between the HO and the skin, the HO and the nerves. And we have to be sure that we have a very safe cleavage plane if you want to resect the HO arthroscopically. And another point, very important point, is the size of the HO. If we have a huge HO on the posterior medial side of the elbow, it's better to approach it with an open approach. But if we have a small HO on the back, on the front, we have a cleavage plane for the nerve, we can approach it arthroscopically. So it's mandatory to make the CT scan. In the soft tissue windows in the axial plane, we have to follow the nerves, the medial nerve, ulnar nerve, and the radial nerve mainly, to understand the relation between them. But where you are in doubt, it's better to approach it open. So sometimes I approach a huge lateral HO opening with a cochlear, extensive cochlear, looking for the nerves, retracting the nerves, and then going inside the joint. So in this way, you are safe. You don't have to risk any time.
Claro, en las osificaciones grandes o las que están alrededor de los nervios, siempre lo más seguro, lo más fácil es buscar nervio sano de un lado y del otro y después trabajar sobre la osificación, y eso te lo permite hacerlo abierto y no artroscópico dependiendo de la localización.
Una consulta, Alessandra, doctora. El tema de la fractura, ¿la artroscopía la hace de inmediato o aguarda un periodo para las partes blandas desinflamen?
In our organization, it's very difficult to bring in your in 1 or 2 days. So we generally, if we have a dislocation, of course, we reduce the dislocation. We put the patient in a sling or a brace for a splint, most of the case, and we ask for a CT scan. We generally bring the patient after 5-6 days after the trauma. In this way, you don't have the bleeding of the fracture, and it's a good window of time to do the surgery. In some cases, I operated the patient after 1-2 weeks. It becomes a little bit different because the ligaments starting to repair spontaneously. You have a fibrous tissue in the fracture, so if you can, 5 days is a good moment.
Perfecto, muchísimas gracias. No hay ninguna consulta más, no hay ninguna pregunta. Bueno, agradecerles a todos a nombre de la Sociedad Boliviana de Ortopedia y Traumatología. Muchísimas gracias, doctor Juan Pablo Simone, la doctora Alessandra Colaza, y a la Asociación Argentina de Hombro y Codo por permitirnos realizar este excelente webinar. Fue muy provechoso para todos nosotros. Desearles que estén muy bien, que se cuiden mucho y salgamos pronto de esta pandemia. Muchísimas gracias por todo.
Gracias.
Bueno, muchas gracias. Gracias, Alessandra. Gracias a todos.
Chao, Alessandra. Gracias.
Chao, cuídense. Un abrazo.
Hasta luego.